Okay. So for the people who don't know Max Wolff is the head of research and training at Mind Foundation, and he's here now today to talk to speak with us about the results of this one of the biggest trial in psilocybin for depression so far, right? Episode study. Yeah, and about a particular aspect about psychological flexibility and avoidance and acceptance as they are measured by the instrument that Max and colleagues developed. It's called the APEQ that Max will show also a little about these very interesting and useful instruments. Okay. And as it is on a journal club, there is no interview. So there is the presenter that just presents, and we can ask questions, we can have a discussion. So Max will not speak for all of the time. There will be plenty of time to discuss, to go in depth in the matters that you want to get in depth. Okay. Thank you, Max. Welcome. And please, as you like, you can start.
Thank you, Daniele. Thank you very much for inviting me. And yeah, good to see you again anyway. So really a big pleasure to have you in the APT network and to also do beautiful things in Italy. So it's really nice to see that how things are developing. And yeah, I'm glad to be involved in it. Yeah. So let me share my screen.
Yeah.
See how this works.
Yes.
And can you see my mouse also? The
Yes.
cursor? Yeah, great. I can make it, let's see, I can even make a laser pointer. That's cooler. Okay.
Here it is.
Yes. Okay, so I'll speak about avoidance and acceptance in the episode trial, a psilocybin study that we did with patients with depression. A few words about my affiliation. So I'm the Director of Research and Training at the Mind Foundation. I direct the APT program. If you're interested in that, you can visit our website. There are some pictures here from the training. I'm also a shareholder of the Ovid-Tagesklinik. This is a day clinic and an outpatient clinic for psychiatry and psychotherapy with a special focus on psychedelic therapies. I'm also a research associate at two psychiatric university hospitals, the ZI Mannheim and Charité Berlin. And the episode study, it's not stuffy, but study that I'm talking about today, it's has been funded by the German government, by the Ministry of Education and Research. So yeah, a few definitions to begin with. So when I speak about acceptance and avoidance today, acceptance, I mean the ability to allow, accept, and engage with negative emotional experiences, and avoidance, the complementary tendency to avoid, suppress, or control negative emotional experiences. And it's important to say also that these are both healthy functions of human functioning, and the pathological it can become pathological when experiential avoidance becomes generalized, yeah, or becomes an overly strong tendency that dominates many aspects of a person's life. Yeah. So with this in mind, yeah, let's look at an exemplary patient report from the episode trial. Yeah. Let me just read this for you. So I had only experienced the deepest shit in those hours. This is from a dosing session. Yeah. There was nothing beautiful. There was no insight. There was no clarity. There was no peace. It was just like the most negative things that I had experienced in the worst phases of my depression, except it was mushroom-like, colorful, and grotesque. And I thought maybe you walk out of here and you didn't make it. In my words, I had failed again. And that made me desperate and terribly angry with myself. And I just wanted to know when it would finally all stop. I was completely frantic about what to do. And I'm sure I was also shouting, screaming, what should I do? What should I do? So this is from an interview with a patient. This is one of the great things about this study, that we did interviews, or the study team did interviews with most of the patients after the treatment. And it's really great to read these interviews and to see what people have to say about the treatments. This is not a patient that I treated, but it's also especially interesting to read the reports and the interviews with people that you have treated, because it's a completely new perspective, and it's really wonderful. And it's also very insightful when it comes to the therapeutic processes, or the subjectively important processes that people report. So what I just read, this is what I would call an avoidance-related experience. Yeah, so negative emotionality, distress, and the attempt to make it stop somehow. Yeah. So this is the same patient talking about the same experience. But then I was able to apply what I had learned before. I'm feeling this now. Why am I feeling this? I don't know, but I just look at it and let it flow through me. And then we just see what happens. And that was always right in every way. I mean, even then, I still experienced some dark minutes, but I no longer felt helpless about that. That was very hard for me in my depression, that I couldn't do anything against the darkness, negativity, because I always thought that I had to do something to counter it. And that turned out to be an illusion. I didn't have to fight at all, or have that one clever thought, or cut the Gordian knot, or have someone else come save me. All I had to do was look at it. Such things can also be read on Facebook and in calendar books. But when you really experienced it, that's something else. Experiencing is just a different quality. So same patient and different experience. Yeah. So it's an acceptance-related experience. I will define this a bit further in a second. And what's also interesting is what happened between those two moments. Yeah, and how could it happen that this person found a way, yeah, to shift their perspective in this way. And you can already see when you look at this that there is an evident, almost self-evident therapeutic value of this kind of experience. Yeah. Yeah, so a bit theory background, so avoidance and acceptance related experiences. What I just read, I'll show it a bit more on the next slides, what exactly I mean by that. These have been described in the qualitative literature. This paper here is a good example. Yeah? Very beautiful description of how people learn acceptance in psychedelic states. So far, there has been no quantitative assessment of these experiences in clinical studies. Although there is an assumed causal relationship. So this is a theory we built. I will show it in a second. We assume that these acceptance-related experiences, they have an impact on longer-term psychological functioning. And it has already been shown here by Rick Seifman that the change from experiential avoidance towards more acceptance, that mediates the antidepressant effect of psilocybin. Psilocybin, but not escitalopram, so not an SSRI antidepressant. So this seems to be a treatment-specific effect of psychedelic therapy. One could also say maybe of psychotherapy. Yeah, of course, all psychotherapies are about reducing avoidance. Here's a theory that we published a few years ago, learning to let go. It's formulated as a cognitive behavioral model. I was trained as a cognitive behavioral therapist. This could also be formulated in more general terms or in terms of other therapy schools. I don't think this principal mechanism is confined to, you don't have to be a cognitive behavioral therapist to appreciate that people can learn acceptance in psychedelic states. So I'm not going to go into very deep details here. The important assumption of this theory is that it is possible to learn acceptance in psychedelic states, or maybe more precisely from psychedelic states. We assume that there's some kind of operant learning, operant conditioning involved. Namely, this is a simple observation that many people who have had psychedelic experiences can confirm, that avoidance, so the attempt to repress or to not think of something that is unpleasant, it often leads to more distress. This may work more or less well in normal waking states. In psychedelic states, it's more difficult. And behavioristically, we could say that this is a form of punishment. Yeah? So you avoid and you get punished by a challenging experience, so to speak. And on the other hand, acceptance, when people learn to bring a bit more openness to the experience, this often leads to immediate relief. And people feel much better already. And they notice it's easier, yeah, when they keep an open mind. And this can be called a negative reinforcement. So this is in part, it's not only that, but we assume that in part it's a conditioning process. We assume that this process is not automatic at all. It's very context dependent, likely. We can discuss later, I think, what context factors need to be present for people to be able to have this learning process. And because it is so variable and context dependent, it's also very variable in how it comes about. Yeah? So some people have this process maybe immediately, others they have a prolonged challenging experience first before they learn that it feels better not to fight or not to avoid. And of course, there's also people, yes.
It is exactly the case of the description that of the patient that you just showed.
Yes, oh yeah, that's one example where the person is really struggling for a long time in the beginning, and then eventually finds a way. Yeah. This is something we see a lot in psilocybin treatment, but it's not always the case. Yeah? Some people more immediately find a way, yeah, to deal with the experience, and others also they struggle the whole time and they never learn it. So it's interesting to think about the context factors that make this possible for some people. And then also there's people who don't even face negative feelings at all during the experience. And then there's no acceptance to be learned, right? Then those people have other kinds of processes going on. But that's a whole different talk. So yeah, more or less persistent attempts at avoidance. So we developed a questionnaire to measure these avoidance and acceptance related experiences. This was published 22. And this is the instrument that we also used in the study that I'm presenting today. So I will just walk you through the whole instrument. So it's a questionnaire with 2 main scales, and each main scale has 3 subscales. So the first main scale, avoidance-related experience. I made this here with a little kind of blue at the bottom and warm colors at the top. Maybe it looks a bit like a sunrise in the ocean or something like that. Yeah.
And also the AC models
Yes,
of
similar.
what?
Yeah.
Yes.
Yeah. I did it a bit on purpose. Similar.
Yeah.
Because the idea here is that they somehow belong together, these experiences. They're not so separable. You cannot have, I mean, some people have one without the other, but they're both part of this therapy. Yeah? And it's important to understand how they are connected, in my view. So around here, these little arrows, they show that, yeah, this is all dependent on the context, or setting, if you want to use that colloquial term. So the first factor here is the avoidant response. So what people actually try to do during an experience. And we measure it with these items here. So I try to lessen or rid myself of certain perceptions or bodily sensations. I try to change my mood. I attempted to suppress certain emotions or thoughts. I made efforts to avoid or control difficult feelings. So you get an idea of what this is, avoidant response. So what's next? So the second factor here, distress. I felt tormented, I panicked, I experienced a state of distress, I suffered from what I was experiencing. This is actually connected very strongly. There's a strong statistical association between these two. It probably goes both ways, yeah? So avoidance increases distress, and distress can also increase avoidance. Yeah? So people can be in a bit of a vicious circle at first. Yeah, that may be what happened to the exemplary patient in the beginning. Yeah, and then there can also be on the cognitive level. So this is more behavioral, attitudinal. This is emotional, and this is cognitive. There can be insights that people make from these experiences. Insight can sound like a positive thing, like something that you want to have. But these are really actually avoidance-promoting insights. I learned to fear or detest certain uncomfortable feelings or sensations more strongly. I noticed that I can tolerate certain mental states less than I thought. I learned that it's better for me not to experience certain emotional states at all. I learned that certain thoughts or memories are more dangerous for me than I previously thought. So if you look at this from a psychological perspective, uh, these are all probably, in most cases, or in many cases, not healthy insights. These will lead to increased avoidance in the longer term. So this is the avoidance-related experience, yeah, all taken together. And on the other hand, we have these acceptance-related experiences. Yeah? The first factor here is complementary, as you can see. Yeah? So this is the response aspect, accepting response. I was able to accept uncomfortable feelings, uncomfortable thoughts or memories. I was open to difficult sensations or emotional states. I looked at painful memories with openness. I managed to confront a personal fear. So if you look back to think of the patient from the beginning, you can recognize already this particular experience of acceptance, yeah, that they had in the end. All I had to do was look at it, yeah, they say. So there's often an emotional quality of relief associated with this, perhaps especially when people encounter this state after a challenging experience, such as the patient in the example. It seemed to me as if some kind of blockage was being resolved. I had a positive emotional breakthrough. I felt a sense of relief. Things became easier for me in a liberating way. And then here too, yeah, people can have insights. I learned to better understand certain emotional states. I discovered a deeper acceptance of certain difficult feelings or sensations. I noticed that certain thoughts or memories are not as dangerous for me as I had previously thought. I learned to appreciate certain uncomfortable feelings or sensations more. So you can already see that this is probably something that if someone has such an experience, they will perhaps be more accepting and less avoidant also in everyday life after such an experience. This is the episode study timeline. And one important thing about the episode study to understand is that there were 2 dosing sessions. People had a first dosing session with either 25 or 5 milligrams of psilocybin or a placebo. And then 6 weeks later, everybody gets psilocybin, either 25 or 5 milligram. So 25 is a typical kind of medium to high dose. It's a standard dose in current psychedelic research. And 5 is more like a mini dose. It's not a microdose. Most people have noticeable effects, but it's usually not a full-blown psychedelic experience that people have. Today we will focus on the first dose, but actually the results I'm showing you today, they more or less replicate for the second dose. So the questionnaire I just showed you, the APEQ or Avoidance Acceptance Promoting Experiences Questionnaire, this was administered after each dose. So in the evening after the dosing session, people would fill this questionnaire. Then we also use this measure, the BAQ, Brief Experiential Avoidance Questionnaire, throughout the study, baseline, and then at different time points during the study. And today we will focus on this first half, but again, what I show you, it replicates also later. So what we're interested in is, do these acceptance and avoidance related experiences, do they predict changes in trait experiential avoidance? So this is a measure that measures how avoidant people are in everyday life. Yeah? If they use avoidant coping strategies, yeah, such as repressing things or postponing things, procrastination, not going into unpleasant situations at all, and those kinds of things. Yeah. Of course, this is something that is very close to depression also. So the hypothesis was that we would see a stronger reduction in experiential avoidance after the high-dose psilocybin session. There's also, we had the idea that the high-dose psilocybin would lead to more acceptance, but also more avoidance in dosing sessions. Yeah? If you think about the patient from the beginning, yeah, they had an intense avoidance experience and an intense acceptance experience. And I think it's fair to assume that this both, yeah, is more likely with high doses of psilocybin compared to low doses or placebo. Then this is the core hypothesis. We assume that more acceptance in dosing session predicts more reductions in experiential avoidance. And also that more avoidance predicts less reduction. So if you avoid very strongly, then you would not have such a good reduction in experiential avoidance. But we also assumed that this effect would be attenuated among patients who show more acceptance in dosing sessions. So this means our example patient, they have both. Yeah. So the idea is, if you have strong avoidance, it's not a problem if you also later find acceptance. Maybe it's even better, yeah, because they have this contrast. Yeah. So this patient, they have a real insight. Okay, first I tried to fight, and it was really difficult, and then I did it differently, and it got much better. So maybe that's even better than just having acceptance. At least that was our hypothesis, because this is also what we found in a previous survey study, in the validation study of the APEQ. This is what we actually found. So this was also our hypothesis here. So this is already results now. Changes in experiential avoidance. So BAQ, this is the questionnaire we have. We have 4 arms in the study. And you can see here, this is the first dosing session. Oh, sorry. Here's the first dosing session. Everyone starts here, yeah, at more or less the same level of experiential avoidance. After the first dosing session, both of the treatment conditions that receive high-dose psilocybin, they drop sharply in experiential avoidance. The others stay the same. Yeah. And then 6 weeks later, those who haven't had the high dose first, they will get the high dose now, and now they also drop. Yeah. And in the end, yeah, so this is after the conclusion of the main phase of the study, 6 weeks after the second dose. It's interesting to see that it's precisely the order of how much psilocybin people got. Yeah, so the red group is 2 25 milligram doses. This is 25 and 5 and 25. Interesting, right? That is difference here.
Yeah.
Yeah. Mm-hmm. Yeah.
Well,
yes. Daniele, yeah. Question?
yeah. Just I was imagining that for the group that took the high dose at D2, they don't drop as much as the group that take the dose in D1.
Yes, that could be. It doesn't. I don't think that would be statistically significant. It looks like it, but it's not that much of a difference. But it looks like a bit of a difference, yeah. And it's also interesting. One could have the other idea. One could assume that it's good, right? If you have 0 or 5 first, then you essentially have longer preparation for the 25 milligram. You know your therapists better. You had a longer process. Yeah, they know you much better. You have more intention setting. You should feel safer in the setting.
Yeah.
So you could assume that that's actually better, yeah, to have this, but at least it's not better. I don't think that it's worse statistically, but it's certainly also not better.
Yeah, but the slope is kind of a bit steeper.
It is, yeah, it is. But the thing is, the statistically, it's not necessarily different.
Yeah.
But this is already a quite large study. I didn't mention this, yeah. So there's 144 patients in total. Yeah, yeah, Maria, yeah.
Yeah, I got confused with this graph. So what I'm understanding is the people that received the 25 milligram of psilocybin experienced marked drop in experiential avoidance, especially when you compare the first with the second. Why is it the same? Sorry, I got confused again. D1, 7 days, less and plus. Okay, 14 days.
So this is 7 days before the first dose, and this is 7 days
Yeah.
after. And
Okay,
there's this
perfect.
difference. Yeah. Yeah.
So it's just the intervention, it's just the psilocybin that caused this, because you were mentioning, you just were mentioning the preparation longer in
Oh, yeah.
the.
So there's also, yeah, I didn't mention this, of course. There's also always preparation and integration. So 7 days before, they have one preparation session. 1 day before, they have another preparation session, then the dosing session, and then on the next day, integration, and 7 days after, again, integration. So this is all of it together. Yeah, we're not looking at psilocybin only, yeah, but also at the psychotherapy sessions. But everybody had those psychotherapy sessions, right?
Exactly. So
Also
both groups
those,
had it, right?
both groups,
Groups
yes. So the
had the
blue,
same.
they also had the preparation and integration, but they had either low dose or placebo. So we can be pretty sure that what makes the difference here is psilocybin. And
Just psilocybin causes a drop in experiential avoidance.
well, probably not. I would say it's still psilocybin in this context, yeah, in a therapeutic context. But yes, yeah.
Yes, exactly. It's within a therapeutical context, but still both groups had the same interventions, and
Yes.
still 25 had a higher drop. So this is interesting because it's like
Well,
just psilocybin.
so the 5 milligram is really not a big dose. So for most people, this is really not an intense experience. It's for many people, it's also not a dose that brings them in touch with problems or with resources. Yeah. Although I will show you on the next slides a bit more about the experiences that people have, yeah, in the different groups. So maybe, yeah, we can look at that, and then it's easier to see maybe, yeah. So in the first session, actually, we only have 3 groups, yeah, because both of these groups here received the 25, yeah? And then we have 5 and 0. So let's look at the next slide here. So this is only the 0, the placebo group, yeah, in the first dosing session. And we have the correlation between the APEQ avoidance scale and the APEQ acceptance scale. And as you can see, almost everyone is at very low levels in both scales. Yeah, so in the placebo group, most people do not show much avoidance and also not much acceptance. Although there are some exceptions here. Yeah, so there is someone here up here that had an extremely acceptance-related experience and no avoidance. So this looks like an extremely therapeutic experience. Yeah. And also these guys here, yeah, this already looks like something happened here in this experience. What's important is that, yeah, nobody really seems to have strong avoidance-related experiences here. Some people have moderate challenges, yeah. Of course, imagine, yeah, you have depression, you're participating in the study, the first dosing session, you hope you get psilocybin perhaps. Maybe you're also anxious, yeah. and then it seems like you're not getting it, yeah, and you're lying there, and of course, for 6 hours with music, that can be an emotional situation, yeah, but it's usually not highly challenging, yeah. But as you can see here, yeah, I mean, for some people, there seem to be some therapeutic process going on. So
Yeah.
now let's look at the 5 milligram, and it's very similar, actually. Yeah, it's very similar, although maybe a bit more of a variability. And then the 25. This is the where you can see the big difference. Yeah, you see this beautiful cloud. Especially, you see a lot of variance in acceptance. A lot of people really have strong acceptance-related experiences, but not everybody. Yeah, it's really a kind of an even distribution. And with avoidance too, you can see, yeah, that is much more avoidance than in these 2 conditions here. Even some cases where, yeah, they probably had quite challenging experiences, but there are no extreme values here too. And that's also important for today's discussion. I believe it's good, yeah, in a study that people don't have these extreme avoidance-related experiences. It speaks also to the efficacy of the therapeutic container, that people were safe here, they were supported. In more naturalistic settings with less support, it could also be that people have more extreme, prolonged, challenging experiences. Yeah. Yeah. I should have checked actually the patient from our report, yeah, from the
Where it was.
which of these points, yeah, it's one of these guys here. I would assume it's probably one of those here.
Uh-huh.
Yeah, could also be here. I don't know, but yeah, something like, because very acceptance related and also quite avoidance related. Yeah. So what's interesting about this here, also that you can see here, that the 2 are not correlated. Yeah, the red lines, you can see there's no correlation. It's not a significant correlation. This is really essential to understand as a therapist too, that avoidance is not correlated with acceptance. When somebody has an avoidant experience, it doesn't mean that they will not have an accepting experience. Yeah? That's a bit, you have to wrap your head around that. Yeah? It's easy to understand when you think of any given moment. Yeah? At any given moment in time, of course, you cannot avoid and accept at the same time, yeah? In the same moment. Yeah? Let's say you have a difficult feeling or a vision that is unpleasant or so, yeah, you can either accept or avoid. You cannot do both at the same time. But the experience is long. It's 6 hours long. And over time, people can fluctuate, like our patient in the beginning. In the beginning, they're avoidant, and then later they're much more accepting. And this can go both ways, of course. And this is really important. There's no association between the 2.
Max,
Yep.
can I say ask something that's really interesting? These 3 graphs. What about the correlation, the not correlation between acceptance and avoidance? That also means that you don't need to have a big challenging experience to actually learn acceptance. No, because I was thinking about some way of doing I don't know, psychedelic work, and they say like make it bigger. Like if I really am in trouble, make it bigger, like actively make it bigger. And you never need to do that, actually.
Yeah, that's a very good question, because some traditions in psychedelic therapy, and also, you know, in psychedelic subcultures, there's this idea that there are no bad trips and it has to be super challenging. And we don't see that. I will show you that in a second. You'll see that that's apparently not needed. The other thing you said is about make it bigger. I think that's still probably a good strategy, because it shows people to, or it motivates the patient to approach instead of avoid, yeah, to desist from avoidance and thereby maybe learn acceptance. And we will see that learning acceptance is actually probably the therapeutic thing about this treatment. So let's look at this. Now it gets a bit complicated and scientific. Yeah. So we look here at the APEQ. Yeah, this is our dosing session, and we look at the acceptance score and the avoidance score. Yeah, this was measured, and then here we look at two variables. This is the psilocybin high dose or not. Yeah. It's just a dichotomous variable. So people have a value of 1 if they get psilocybin and a value of 0 if they have the low dose or placebo. Yeah. And you can already see that this is a positive sign. Yeah. So in this regression model, the high dose predicts both higher acceptance and avoidance. Yeah. This was our hypothesis. Yeah. Of course, yeah. When people have the high dose, they will more likely have stronger acceptance and stronger avoidance-related experiences. That's the same thing that we see here, actually, yeah. So you see, as the dose increases, especially here, you have more acceptance and more avoidance, yeah. So that is what you see here, those two numbers here. APEQ, this is baseline avoidance, the brief experiential avoidance questionnaire, a week before. And this is also interesting. One might assume that more avoidant people have more avoidance-related experiences, right? Because as psychologists, it's a bit puzzling. In psychology, we always assume that one behavior predicts itself, yeah? And it doesn't seem to be the case here. No association. But avoidance, what it does predict is lower acceptance. So those who are strongly avoidant at baseline, they seem to have more difficulties finding acceptance. Yeah. So now the main result here, this is our outcome, yeah, the APEQ 6 weeks after the dose. And first of all, you can see the psilocybin, it doesn't have an effect here anymore, but that's because the effect of the psilocybin is explained, is mediated through these experiences here. The APEQ at baseline also strongly predicts the APEQ after 6 weeks, which also makes a lot of sense, yeah? So if you start with high avoidance, you're likely also relatively avoidant later, yeah? And now the important result is here. So acceptance predicts a reduction, the stronger acceptance-related experience someone has, the more decline or the more reduction in avoidance they will have later. And this here is interesting because this shows the avoidance-related experience is not associated with changes in avoidance. And also, this is the interaction between the two, the interaction term, yeah? It's also not significant. So that this means that the effect of acceptance on experiential avoidance is independent of avoidance, yeah? There's no statistical interaction or moderating effect. So, this is a very, I think, useful result clinically, yeah? Because I think what we can take away from it is that we should first and foremost help people have acceptance-related experiences. We should not avoid, or we should not at all costs help them not have avoidance or reduce avoidance. Yeah, and we should also not force avoidance. Yeah, so this is something that maybe Stan Grof would have said, that it's good to to bring people in situations where they will become more avoidant or so. Yeah, and we don't find evidence for this. So looking back at the hypothesis, so stronger reduction in APEQ after the high dose psilocybin, this was confirmed. High dose psilocybin leads to more acceptance and avoidance. This is also confirmed. Acceptance predicts reduction. This is also confirmed. Only the last thing here. So the hypothesis about avoidance was not confirmed. I can explain it. I can try to explain it. So first, the conclusion, yeah, acceptance-related experience mediates the reduction in experiential avoidance. Why don't we find an effect of the avoidance-related experience? I think the answer is here. We don't have in this sample people with strong avoidance experiences. Probably because it's a safe setting, people are well prepared. There's a therapist always there. When somebody has a really challenging experience, we can help them. So the negative effects may just be mitigated by careful preparation, integration, also selection of patients. These negative effects, they may be much more common in less controlled contexts. And that's what we actually found in a previous survey. Naturalistic psychedelic use, we have more extreme values here in some people, and then it really predicts also negative longer term effects. So the fact that we don't find an association between avoidance-related experiences and the outcome, in this case, experiential avoidance after 6 weeks, that doesn't mean that avoidance-related experience should be ignored. So they're of course still relevant to clinical practice. They often require therapeutic interventions. They also may lead to dropout. If somebody had a terrible experience in the first session, they may not come back to the second session. That's also maybe part of the explanation here. We had a handful of people not return for the second session.
Oh, the drop out before the second session.
Yes.
Oh.
Very few, but it did happen. Yeah. And it can also play a very important role in the patient's narratives. So if you look at again at our example from the beginning, for this patient, it's a really important experience that they had this avoidance focus in the beginning, and that it shifted later, and then it became easier for them. So the clinical takeaway is therapists should focus on promoting acceptance. We can discuss how to do that, but I think it's very, very clear that that's what we have to do. It's also, I think, most of the preparation work that we teach in APT is actually associated to this goal, to help people develop approach motives to their problems and to become open to actually looking at painful things. And the other thing is we should neither excessively prevent or avoidance or purposefully induce it. So some traditions in psychedelic therapy, they assume that yes, people have to have a challenging time, otherwise it's not therapeutic, and at least we don't see that here. And then of course the important thing, something that we didn't look at in this study, is the context factors. We should investigate that in the future to look at what actually promotes acceptance, therapeutic relationship, maybe certain therapeutic interventions in preparatory sessions, in dosing sessions. So in the APT program, right, we have this, you remember maybe this crosshair model?
Yes.
That's essentially to help people have acceptance-related experiences in the ideal case. Of course, that's also something we do focus a lot in APT, building approach-motivated intentions. And eroding avoidance motives before dosing sessions. And then also some trainable capacities, such as mindfulness, self-compassion. These are topics that we see again and again in the qualitative reports of patients, that they made use of mindfulness, that they made use or learned self-compassion. So these are things I think to look at more in future clinical studies. I think that's it from my side.
Well, thanks, Max. And I will not like to speak to make an interview. I would like somebody to also ask questions to Max. We have the pleasure to have the author here, and so feel free to ask any kind of questions, and that Max will be happy to go in. I know Maria, Susanna, Gabriele, Alessandra. Alessandra.
Hi, everyone, and thank you, Max, for the great presentation. I just have a question regarding the selection of the participants in the study. Were they people that already had experiences with psychedelic substances? Was it mixed, or
Yeah.
they had no experience? Because I feel that that will also definitely shift the level of acceptance that the person has experienced and knows.
Good question. So previous psychedelic use was not a hard criterion. I think we defined that people shouldn't have had, I think, something like 6 experiences, or 5 or 6 in their lifetime
Yeah.
with classical psychedelics, and the last one should be longer than a year ago, I believe. So nobody here was extremely experienced with psychedelics. Most were unexperienced with psychedelics. It would be interesting to look at the association between previous psychedelic use and avoidance acceptance in the psychedelic state. Although there's also one caveat. A lot of people who have psychedelic experiences have still little experience with introspective experiences. So most people who have psychedelic experiences, I believe, have experiences that are in social settings, in nature settings, in interactive settings that are more externally focused. And the setting here that we use in the clinical trials is quite different from that. So people are internally focused for hours. There's this aspect of sensory deprivation. And we found some evidence in the APEQ study, in the validation study, that this kind of introspective, non-interactive type of psychedelic use promotes these acceptance-promoting learning processes, because you cannot easily distract yourself, and the whole dynamic, what I showed before in learning to let go. Yeah, so these learning processes that it becomes easier when I open myself up, or it becomes more difficult when I fight. That's very easy for a person to observe, or relatively easy for a person to observe, when they're not distracted and when they have their eyes closed, and when they don't move around. And when you can distract yourself and when you can move around, and then this is much more difficult to discover. Yeah.
Yeah. Thank you.
Welcome.
I have a question. Well, I have many actually, but I'm gonna start off by one, just one. How is mystical experience related to this approach, avoidance? Approach and avoidance, or acceptance and avoidance.
Very good question, Maria. Should I look it up? I will tell you I will actually tell you the correlation. Yeah. It's not strongly related, but it's a good question. I will first tell you the correlation, and then I will tell you what I think about it. So in the APEQ validation study, we used wait. Wait. It's not here. Just a second. So we had a recent study where we used the APEQ and also the oceanic boundlessness scale of the altered states questionnaire. The oceanic boundlessness scale is very closely related to the mystical experience questionnaire. It's a correlation of almost 1. Yeah, so it's basically the same construct. So let's treat it like mystical experience. So the oceanic boundlessness correlates with APEQ acceptance 0.59, 0.6. which is a moderate correlation. And with avoidance, zero. No correlation at all. Yeah. Not a negative nor a positive correlation. Yeah. So I think the correlation with the positive correlation with acceptance is again an interesting question. Why is it correlated? So we had in the Learning to Let Go paper, we have a discussion about it. And one idea is that mystical experiences are an outcome of acceptance-related learning processes. Yeah, or they can be at least, because when people stay in the experience, except of going out, yes, removing the eye shades and distracting themselves, they can much more easily find intense experiences, such as mystical experiences. And this can then again be a reward, actually. Yeah? If you think of it in a behaviorist term, imagine a mystical experience as a reward for learning acceptance. Yeah, that will really teach you something, maybe. Yeah. On the other hand, it could also be the other way around, that people have a mystical experience, which are often, as we know, they're resource activating. So people through mystical experiences, they discover very often approach motives. What is important in life? Yeah, values, things like relationships, connectedness, nature, spiritual stuff. Yeah, and these things, they give people meaning, and also they can motivate people to look at problems and to confront problems. This is actually a common factor in all psychotherapies, not just psychedelic therapies. Yeah, that people find something that it's worth for to change. Yeah. So my idea is it goes both ways. Mystical experiences facilitate engagement with problems, and engagement with problems and acceptance may facilitate a mystical experience. Sorry for the long answer.
That's very interesting. It makes sense. Sorry guys if I'm asking too much, but the other question is how to promote acceptance in patients. You already mentioned the crosshair model. You mentioned mindfulness and self-compassion techniques, it would be, right? I don't know if I understood well, but what else would you include besides the way preparation is done in terms of asking questions in this more motive approach.
Yeah.
Am I saying it well? Way that it's related with the other day I was studying motivational interviewing.
Mm-hmm. Oh yeah.
And it found it very, very, very similar.
Yes.
So the question is how to promote these experiences in preparation sessions.
Yeah, so motivational interviewing is a great skill, I think, for any psychotherapist, and especially for psychedelic therapy, perhaps because it's essentially it's about developing approach motives. Yeah, again, what I said before. Yeah, so people need to be, in order to do the difficult work, yeah, to look at your problems and to accept them first, and then maybe change them. You need to that has to be good for something. Yeah. So. And that's a bit of a chicken egg problem, of course, yeah, because sometimes, very often with, let's say, with severely depressed patients, it's very difficult, of course, to find something that's really an approach model, or that feels meaningful and valuable. So we can look for little things. Yeah, I think that's what we have to do. Yeah, and then it's also an iterative process. So people come out of the experience or out of a session with something, and then you work with that and build on it. So I think that's the essence of any psychotherapy, is to build approach motives, to use the resources that the person has, their positive relationships, their goals and aspirations. Maybe also the things when they're completely out of touch with these things, to look at the past also. What was important in the past, maybe. Yeah. Those are all ways to get there. You could also, what I like to do in psychedelic therapy, we don't have that much time, yeah, in the studies, especially because it's very, very brief preparation time. I like to ask people, what would you do if the depression was away? Let's say this treatment works. I always tell people it doesn't work like that mostly, but let's just say it just blows the depression away. What would you do then, yeah, as a non-depressed individual with your life? What would you like to do? And that's a bit of a puzzling question for some people, because sometimes they have been depressed for 30 years. Yeah. So it's very good to take time to think about these things. And once you have a bit of a handle, yeah, once somebody has expressed something like, I don't know, I want to be there for my children more, or something like that, yeah, or I want to enjoy ice cream again, yeah, I don't know, yeah, things like that. From that, yeah, it's much easier to build an intention to also accept the difficult parts of the experience. Yeah. So intention setting, I think, is a very essential, important thing. But then also, as you said, yeah, actually preparing people for what to expect, and psychoeducation. Let them know that actually not everybody has to reinvent the wheel. Yeah, it's fine if they already know that it's easier to accept. Yeah. So what I like to do is I like to tell people about it. You can use metaphors. Yeah, the monster thing, for example. Yeah, the monster. Imagine you find a monster or a spider if your patient is a spider phobic, and let them play with the thought of running away and then going there and trying to touch it or ask the spider, what are you doing here? What can I learn from you? Play with approach and avoidance motivation. Nowadays, also related to the results that we found here, I wouldn't tell patients not to run away. That's fine if they want to. It can be a valuable experience. I would just try to motivate them to be a bit more playful with it and to try different things. So maybe you can run away and observe if it makes the fear better. And if it doesn't, you can maybe try the other thing, yeah, and go to the spider and ask them some questions. And then this is something that we can again do in the dosing session. Remember what we talked about. Yeah. How about you try go into the experience instead of running away also. Probably good to work with metaphors and images because that's more accessible in a high dose psychedelic state. Yeah.
Thank you, Max. I just want to ask you about this last thing, that it's important in terms of and how we do engage the person during the experience, that you don't have actually to, of course, we know the crosshair model, me and Maria, because we did the APT, but I don't think the other person. It's basically a crosshair which it's like a guidance for the therapist or the sitter to how to deal with some different reaction of the patient, of the person having an experience. And basically it's all about promoting engagement by the person in the experience. That actually it's different than promoting engaging the monster. I mean, it's different because engaging the monster is gonna be like go deep into the horror, like that avoidance setting that the study already just showed that it's not useful. So I mean, this is the really important part because a lot of people they they do actually in the psychedelic field and therapy tell people to go deep into the mess, into the shit, as the patient said. No, so actually there is no need to do that when you are during the experience. You don't need to actually go deep into it, but just stay inside your conscious, just stay in the experience wherever it goes. That's the meaning, right? If I get it right.
Well, it depends on how you tell people and what they understand from it. I think, something that I could do is, and what we actually also tell people in this study as one possible strategy for handling challenging experiences is, one thing is always, of course, just observe, yeah, and stay and look at what's happening, notice, yeah, in essence, mindfulness. But we also, because we want to give them a repertoire of different options that they can try, which also gives them a sense of control. Yeah, if they have the more possibilities they have, the better equipped they feel and the more confident. And another tool that we practice also is to go deeper, actually. Yeah, so to try to make it bigger. It's not a must. It's not something that we say you have to do this. It's more like another thing that you can try. So yeah, like
Not mandatory to the
yes,
efficacy.
yeah. So play with it. Yeah, and some therapists, I think, have used also the kind of FOMO, yeah, element. So when there is a spider or a monster or so, then hurry up to go there. It's not like it's your best chance to learn something
Chase
about
it.
yourself.
Chase it.
Yes, chase it and don't let it escape. Yeah. So it's a bit of it plays a bit with avoidance motives versus approach motives. So right, to I think it's really important to not, we don't have to do it in exact this way, but patients should understand that whenever something makes you scared or sad or when something is emotionally challenging, that there might be some therapeutic value in engaging with that instead of trying to make it go away. Yeah? And that can be achieved in many different ways. Yeah? So I would say it yes, it's good to motivate patients to try to engage with it in different ways. I would agree with you, Daniele, that it's probably a bad idea to tell them you always have to go in, always jump in, make it as big as possible always. I wouldn't say that because there's also a chance that that's not possible in the moment, and then people feel bad about that. Yeah, and
Yeah, maybe that's a way to just cause a panic attack to a person.
yeah.
Yeah.
So my approach is to make it a playful thing, create approach motives, make the problems seem interesting and the scary things, convey the idea that it can be helpful or it can be valuable to engage with them. Yeah.
There's other questions? Maybe Maria, I know that she has a lot. Gabriele, she wanted to ask something. Hello,
Yeah, I
Gabriele.
just wanted to thanks Max for the presentation. I really appreciated it. Unfortunately, today it was not perfect day working for me, so I just have to go now. But thank you again for this meeting, and also thanks to Damiano for this opportunity as CMAPC.
Thank you, Gabriele. Yeah.
Ciao Gabriele, grazie di essere partecipato, spero alla prossima.
Alla prossima.
Ciao.
Tutti.
Yes.
I have a question.
Mhm.
First, I would like to know about the exclusion criteria, especially for psychiatric comorbidities.
Mhm. So in the episode trial, yeah, I actually I didn't present the whole study. I also didn't show the main results of the study today. So the episode trial, people had to have a current major depressive episode, and they had to be treatment resistant defined in psychiatric terms. So in the current depressive episode, they should have tried 2 different types of antidepressant without treatment response. So that's the main inclusion criterion. And then exclusion criteria were things like psychosis, bipolar disorder, PTSD, severe personality disorders, acute suicidality. Yeah, these are the most important ones. Yeah.
Okay, and the second question is usually psychedelic studies focus on resistant depression. What about personality disorders? If you know about any study, or what do you think about it?
Yeah. So to my knowledge, there's no specific study, and personality disorders, I mean, there are many different ways to conceptualize that. Usually, still, personality disorders are considered an exclusion criterion in many studies, at least certain personality disorders. I would say it depends also on the kind of personality disorder. So with, for example, borderline personality disorder probably needs much more of a therapeutic framework than what is done in most major depression studies. Or narcissistic personality disorders probably, in my view, cannot be treated reliably with, first of all, with high-dose psychedelics and with this introspective setting. I would assume that they require lower doses and an interactive process-directive therapy during the dosing session, because people with higher doses, people will just jump out of their vulnerable basin, because let's face it, a narcissistic patient will not come into treatment while they're grandiose. Yeah? They only come when they're in a vulnerable state. And then what will happen likely is that a high dose of psychedelics will just catapult them back in the grandiose, and then they're healed. But of course, yeah, this does not solve the problem at all. I mean, it can be, of course, a valuable thing, but it's probably not a sustainable treatment of the underlying problem. So what I would like to see in the future is a lower dose trial that is more similar to the classic psycholytic therapy, but maybe using something like emotion-focused therapy or compassion-focused therapy, and really guide the person to the shame, yeah, and to the threatened self-esteem, the things that are otherwise avoided, yeah, by those people. So I think that's the way to help narcissistic individuals. This is just a theoretical idea. I don't think there's much research to support it, but I think anecdotally, yeah, we can all agree that the psychedelic field, there are not less narcissists than in the rest of the world. So
Maybe
somehow
this is also even greater, but
can be, yes. So
yeah.
it seems to be very well possible to have many psychedelic experiences without changing anything fundamentally about narcissism. That's a bit of an elephant in the room. Yeah.
Yeah, and maybe that's the population you were referring to when you're speaking about that there are these 2 main avoidance experiences and acceptance experience during the psychedelics experience again. But and you said that okay, there are other people that just have nothing, just a really pleasant journey and nothing big. That could be really cognitive avoidant people, or a really experiential avoidant people, like or narcissistic style personalities, bipolar style personality. And I think the psycholytic way of will be so interesting to explore. But my question is, could it be done during a trial? Because maybe personality disorder really need long periods of to just create a safe container, because personality disorder, if we want to look at them not like just a diagnosis, but anyway, is something that is really it goes along all the history of the person. So it shapes all the things and experience the person actually do. So if we don't work with that person and they're egosyntonic. So you first have to work a lot before maybe exposing a patient but I think maybe during a therapy with a narcissistic, if you are able to keep him after the depressive period, and when he's looking back from the higher tower and say, I ain't gonna back into the world and do my stuff. If you keep it in therapy, maybe you can actually, after the second depressive episode, I don't know, you can actually work with him. But I mean, in a clinical practice, not in a trial. Trial is impossible.
Yeah, I think this will be interesting to explore. I don't think we will see any clinical trials, big clinical trials soon, with at least with narcissistic or borderline. We will see, I mean, many patients with treatment-resistant depression, they do have personality disorders. Sometimes it gets reported in the trials. We had in our trial, we did have some patients that certainly had for example, an avoidant personality disorder. Yeah. And for that, I think it can be the same protocols can be used that we use for just ordinary TRD.
Yeah, ordinary.
Yeah. Garden variety TRD. Yes.
Can I ask a last question?
Sure.
Regarding the dose, you mentioned that 25 is not high. What would you
medium to high? Yeah, I would say it's
because I have no idea of psilocybin, in terms of psilocybin, what is considered high, and the differences that you could expect from this medium high to a high dose in the clinical setting. What would you say in the patient experience?
Yeah. So I think actually the 25 for many patients, it is a high dose. For many patients, this is a dose where they, at least during a portion of the experience, lose their complete sense of self. And more really wouldn't make sense for many patients. But for others, the 25 is really only a medium dose, or for some people even a relatively low dose. We did have some patients who didn't report many subjective effects. We actually had one patient in the study who, on a 25 milligram dose, almost didn't experience anything. So that exists too. I believe in clinical practice in the future, outside of clinical studies, it will likely be that you do a dose finding first, and you probably will not start with 25, but with 15.
Interesting. Never heard that before. So because it seems that the measuring or calculating the dose regarding weight is not common practice, and apparently there's nothing to do with weight. It's more related with receptor activity, right? So that's very interesting. So thank you.
It is like ketamine.
Yes. Yes. Yeah. Okay, guys, any more questions? Doesn't look like it. Well, thank you very much for coming, and hope to see you again soon.
Thank you, Max.
Thank you so much.
Thank you all to be here. Ciao Maria.
Ciao a tutti.
Ciao Maria, ciao a tutti.
Ciao Susanna, ciao Alexandra.
Ciao.
Ciao.
See you soon. Ciao.
Grazie.